the question to Vivek. In a busy hospital, general hospital, and you have a lot of colonoscopies and upper endoscopies. How do you decide how many you can do? I mean, the list is something. When you say proper therapeutic colonoscopy and proper therapeutic upper endoscopy, how do you adjust your endoscopy unit? How many colon? What is the timing you give for therapeutic, all polyps and upper?
Yeah, so that's an operations question. So it varies from place to place. I think what your question really is, what is a reasonable schedule for upper endoscopy, colonoscopy mix?
And ERCP.
And now you're adding ERCP. Okay, so in general, an upper endoscopy can be done, I'm talking without trainees now, just you. From start to finish, including the paperwork, documentation, and everything in about 30 minutes, 30.
Pre, intra, and post?
Pre, intra, and post. Most upper endoscopies that are not complex endoscopies should be able to be done. Then it is possible to turn the room over in about 10 to 12 minutes. That's our national benchmark right now for that. So now we're at 45 minutes. So I think if you schedule your patients around 45-minute mark, then I think it's reasonable. Anything less than that will be difficult. You should also factor in whether moderate sedation or propofol is being used. I believe that there is some difference, but at the end of the day, I think it's the room turnover and your personal efficiency that is more important than what anesthesia you're using. Because anesthesiologists also can vary very much in
No, moderate sedation.
Moderate sedation, 45 minutes with a good team. If you turn over, fine. EGD, biopsy is fine.
Colon, ERCP.
Colonoscopy, if your cecal intubation is consistently less than 4 minutes and your withdrawal time is 9 to 10 minutes and you're doing standard polypectomies, not what she showed us, then again 45 minutes is doable, but 1 hour is more realistic for colonoscopy.
ERCP, the same?
ERCP, the minimum standard we have is 60 minutes with general anesthesia, and we add another 35 minutes to that for room turnover because intubation takes 10 minutes, extubation takes 10 minutes, room cleanup takes another 15 minutes, equipment preparation. So ERCP will be 60 plus 45, 105 minutes.
Okay, excellent. Asma, you are always superstar. And I'm always amazed and I'm happy about your performance. And you are, we are very happy with you. So tell us, for a general gastroenterologist like me, how many EMR and ESD I can do so you can say I'm fully practiced. What is the number?
Like for EMR, for more than 20 millimeter, you have to watch around 60 and perform around 20.
Watch 60 and do 20.
20.
Okay.
For ESD, you have to do 40. And it varies between 25 and 40. You have to do in live animals up to 80. Not live or model, live animals models. And this is varies actually.
من فين أجيب الحيوانات؟ عندنا حيوانات كثيرة لكن أنا just asking يعني. Very interesting.
And you have to perform between 25 to 40 under supervision.
Excellent. But I'm worried about ESD and a good pathologist. When it comes to it looks deeper, submucosal. Is it better to do if the patient is safe to do? Because the chance of recurrence is higher in submucosal
invasion.
Invasion.
That's
yes.
why you have to have a good pathologist. And we were lucky in Kuwait. I don't know if Muhammad is here. We have Dr. Muhammad Al-Kindari. He's a GI pathologist, where he just measured the submucosal invasion. But if it's less than 1 millimeter, what you have done is a curative. And if it's more than 2 millimeter, there you have to look for the other parameters. Now, if you have single factor, you can just watch and see. But if you have more than, like lymphovascular invasion is an independent factor where this patient should go for surgery.
Excellent. And the question for our beloved, I'm really constipated. So if it is severe constipation and everything is failed, and you decide to do surgery, what is the best surgery for complete colonic inertia? What do you suggest to the patient?
Well, what our surgeons are doing in UK is that they have 3 options normally. They suggest first, if the patient has still the appendix, they perform the Malone procedure, so they attach the appendix to the abdomen, and you can propose the patient to do the irrigation, the anterograde irrigation from that side. So this is the less invasive that you can propose to the patient, but depends also from how is the anatomical presentation of the patient. The second most frequent done is the temporary ileostomy. So they offer this as a kind of way for the patient to understand what is the life with the bag and whether they are then satisfied with having a bag there. And really the last option that they normally propose, but really in very selected cases, I can tell you that over 20 years I probably had only 3 patients treated with total colectomy, and it's normally the removal of the entire colon, because in the past they were used to do segmental resection of the colon, but now we know that these are kind of making the situation worse rather than treating the patient. So if you go for the most invasive one, it needs to be a total colectomy with ileorectal anastomosis, which is really an invasive treatment that I don't recommend to do so easily.
Thank you. So, do you have any other questions?
I have a question, Dr. Amar. So, regarding for the, what do you think the best best candidate for transanal irrigation device in patient with refractory constipation, and for how long?
Best candidate, every patient can really be proposed, and this is something that nowadays, at the beginning I was just using in patients that were refractory to any medical treatment. Now I'm combining in some patients where, especially those patients that have chronic constipation together with fecal incontinence, because this can happen, fecal rectal irrigation can be really a good option. But in general, to any patient that when you propose to the patient, you explain what this is about, if they feel that is something for them, you can do it, and it's something that they can continue in the long term. Normally, the only limitation is that the patient don't like the idea of relying on this and doing this many times over the week, because of course takes some time. You need to dedicate something like half an hour of your evening, so it depends. But when it works and when the patient is happy, it's really one of the best treatment that you can.
I think we can close now. So thank you very much for the great session. Thank you, the speakers and my colleague chairperson. Thank you, everyone, for this day, and see you tomorrow for the new Apple.